thing. We have Dr. Sirisha Senthil again. Thank you so much, Dr. Sirisha. I feel as if I'm on a roller coaster right now. And with all of top view
Chitra
here.
needs a break.
Yeah, I truly. Yeah. No, but then how could I exclude all of you? I can't run a meeting like that. So she's again heads the glaucoma care at LV Prasad Eye Institute and specialized in cataract, glaucoma, and children eye care. And she's going to talk again on an honest appraisal of the utility and techniques of MIGS and micropulse laser in Indian scenario. On to you, Dr. Sirisha.
Yeah, so I thought let me start with what these actually mean, because some of us may not even know what this micropulse laser is. So what is micropulse and how different is it from the continuous wave diode laser that we use? So the laser mode that breaks up the continuous wave laser into short repetitive bursts. So basically in between there is a cooling off period, and what that does is it decreases the amount of energy that is delivered and obviously a collateral damage. So in TSC-PC, we know we blast the ciliary processes and you hear a pop, whereas in the micropulse laser, what you do is you use a probe to sweep on the tissue of the ciliary body, more so of the pars plana, and it possibly gives a thermal effect. It causes a low-grade inflammation of the ciliary body. You don't hear any pops in this tissue. Apparently, in fact, when I asked Paul Chu, how does it work? He said, I don't know how it works. He said it works. We know that, we've seen that, but I cannot really tell you what the mechanism is. But people describe and hypothesize that it works like pilocarpine, where it helps to work on the ciliary muscle fibers and possibly helps to open up the scleral spur and the trabecular spaces. But there are two versions of these micropulse probes that we have. The currently version 2 is being used. So the settings are based on multiple settings that have been used in various studies. Basically the power is almost the same as what we use with the TSC-PC machine, but I think the dwell time or the time that you use to sweep the probe is much shorter. So it is like a painting of a brush that you do on the superior quadrant and on the inferior quadrant in a sweeping motion, and that can be done either fast or slow based on what is recommended and what your results are in your hands. So I try to gather up the evidence that is there for micropulse laser. So it is very, very confusing evidence. Some of them say they are fantastic, some of them say it doesn't work, some of them say there are just too many complications. So I try to be honest in trying to gather what information we have. So this was a study, majority of the studies if you see are from the Singapore group. This was our first study that was published, where the results are closed in prospective study of 40 eyes. Success rate was 80%. Again, the definition of success is IOP less than 21, more than 6, with or without anti-glaucoma medication. So with medication it is 80%, but we need to also remember that in their study they did not consider repeat micropulse laser as was not considered as failure. So which means that even if somebody required a repeat laser, it was still considered a success. This was a study that I came across where actually they compared the DLCP with the micropulse laser. At 1 year, they found that the results at 6 months and 1 year, the results were slightly different at 60% and 40%, but by 18 months, there was no significant difference. Numbers were not huge though, but the ocular complication rates, according to them, the continuous wave had a little bit more complications. Again, when you have 48 patients and 48 eyes, when you say little bit more is one more will be about 10% more. So that's how it is. That was the only study that I came across where there was a comparison, but there was a large study that was published by a group where they looked at a retrospective study though, but multicentric, where they had looked at people with good visual acuity with no prior glaucoma surgery. How did the micropulse laser work? So they found that the IOP reduction was not so great. By the last follow-up, it was only about 36%. But what was interesting is even the number of medications came down from 3.6 to 3.1. So there were not a significant drop in the medications, but what was also more interesting is more than one line drop in visual acuity was found in 42% of the eyes. So beware when you use this for people with good visual acuity. And more than 3 line loss was found in 50% of the eyes. Mydriasis was a serious complication they found in several of these patients, which could be very difficult for some of our patients, especially if you are treating them for the first time and if they are young. And some of these eyes also lost light perception. So with single surgery, about 36% success, repeat surgery, about 60%, close to 60% success was what was found in their study. So another study that again looked at these 207 eyes, where again if you see it was almost similar to what we saw. 3 years it was 18% was the success rate, but What is difficult to accept is the eyes that had thisis were 7, meaning like even if it was let's say 7 out of 207 in eyes that were seeing, I think I wouldn't use this as the first option. There was this one study from India from Murali Ariga's group where hypotony was also noted, but their success was quite good at 3 months. So to summarize, it is just an adjunct. I don't think I would use this as a primary procedure, especially considering the fact that hypotony and thisis are a serious issue. Cost is a problem because this is a single use probe. So Chitra, you have to give me 2 minutes more because you've given 2 topics. Trabeculectomy is the gold standard. So I don't want to go through all of this. We know MIGS is something that is here for, and I don't think we should run away from them. Newer technology, we should definitely try and embrace it. But what is important is understand what is good and what is not so good, and try to see where we can use it to the benefit of our patients. There are several of these MIGS procedures. I don't want to go into the details. MIGS are definitely increasing even in our country. They are different, slightly different in the sense like you're trying to use your multiple methods to try and improve the natural passages in the eye, apart from creating an passage that we otherwise do in a trabeculectomy or an implant surgery. Infranasal area has the maximum collector channels. There are various techniques that we do, at least in India. Since you specifically said for India, currently what we are doing is the bang, KDB goniotomy, the GAT, as well as the eye stent as of now that we have. The other procedures that are there, I'm not going to the details because we don't have them available in our country. A piece of evidence that I found was very useful, what all of us should understand is, any new technology we should adopt, but try and use the information that is available in the literature to see whether the long-term outcomes are good and does it really help your patient and what are the specific indications. So with eye stents, apart from hyphema, what was very disturbing to note was close to 50% of the stents were embedded in the tissues that were inserted. So that means they were malfunctional to begin with. So that is something that one needs to understand, and cataract formation of course is a issue. Hyphema is a huge problem, and for GAT and for the angle-based procedures, the trabectome and the KDB, hyphema is a serious problem that we also deal with, and IOP spike is again a big problem. So advanced glaucomas, one should be very, very careful in using these techniques. It's not that we don't use, but beware of this problem as well. The other subconjunctival procedures, anything subconjunctival and you're creating an artificial fistula, or you're using a device to make a fistula, hypotony and erosions are an issue as well. So what do they have to offer us? They definitely help to decrease the number of medications, possibly better safety. But remember one thing, just because they are safer, you don't have to use them because they also have to be effective. So a technique has to be used only if it is effective, and of course affordability and the cost and availability is a serious issue. So at this point in time, I would say MIGS is great promise. There are no standardized definitions for success. They can be individualized and used based on the availability that we have. Plus, I think you need to taper your use as per the requirement for the patient.